Good evening, everyone, and let me be the first to welcome you to our presentation this evening, Hepatitis C donor positive to negative liver and kidney organ transplant recipients. This is presented by one of our liver experts from St. Louis University, Dr. Elbeshbeshy. I'm Jackie Dominguez, the National Senior Director of Engagement, and I'll be making some brief remarks before we begin our program. Please take a moment to look at the disclaimer on the screen. We feel it's important for all of our guests to know that this program will be recorded for future viewing, and this information was provided during the registration process. After this event, we'll send everybody a link so that they can access it. It will be posted on our YouTube station. The vision of the American Liver Foundation is a world without liver disease. And we strive to accomplish this through our mission of promoting education, serving as advocates for the liver patient, providing support services, and raising funds for research for the prevention, treatment, and cure of liver disease. We encourage you to visit our website as we have a multitude of medically vetted resources for your patients and enduring materials for you so you can keep up with what's new in liver health and diseases. We also invite each of you to check out our medical advisory councils across the US. And if you're not already a member, we can tell you how to become one. As is true with all not-for-profits, we rely on your generosity to fulfill our mission. And we encourage you to make a donation or join us at any of our fundraising events throughout the year. We also encourage you to visit us on our social media. And if you have a Twitter account, please retweet for us and please follow us. Just a few housekeeping notes. For this evening's program, we ask that you remain on mute, turn off your cameras to help increase our internet stability, and enter any questions you might have in the chat. Again, I want to remind you that this program is being recorded. Our Missouri Medical Advisory Committee member and champion of our educational series is Dr. Stephen Fern from Specialists in Gastroenterology. I've had the honor of introducing Dr. Fern on several occasions, and words are not really adequate to share how amazing he is. If you don't know Dr. Fern well, rest assured, he is a passionate patient advocate and an amazing friend of the American Liver Foundation. I'll let him tell you more about his love of sports, family, and friends. And as you can see, his accomplishments are more modest than the man himself. It's an honor to know him and a real pleasure to turn the program over to him to formally introduce our speaker for the evening.
Well, thank you, Jackie. That was quite a nice presentation, a nice introduction. I'm always humbled when I talk to Jackie. It's always so much fun to be with her and to participate in the American Liver Foundation. So tonight I'm going to go right into the program. So I know Dr. Elbeshbeshy. I've listened to him lecture many times, and I just am so excited to hear him talk tonight. Dr. Elbeshbeshy is an assistant professor of medicine in the department of, or in division of internal medicine at in GI department of St. Louis University, and is part of the liver transplant team. Like I say, I've known Dr. Elbeshbeshy for a little while here since he's moved to St. Louis, and have listened to him lecture many times. So really, without further ado, I'm going to turn it over to Hani and let him take his presentation on hepatitis C donor positive never liver and kidney organ transplant recipients. So Dr. Elbeshbeshy, over to you.
Thank you. Let me just share my screen. Can you guys see my screen now?
Everything looks good, Doctor.
Definitely. Everything looks great. Yep.
So, interestingly, when Jackie was putting the first slide, it said mission for ALF is a world without liver disease. And here we are talking about inducing liver disease to clear the world of liver disease. So just kind of paradox going on there. And we're talking today about Hep C donor positive to negative liver and kidney organ transplant recipients. So as an introduction, so the idea is to provide liver transplantation to really sick liver patients who are awaiting liver transplant, and for that matter, kidney patients also, who otherwise will potentially deteriorate or die if they don't really receive an organ in a timely fashion. Really what prompted that is, the idea has been there for a long time, but what prompted that is the discovery of direct-acting antivirals. The new medications that been curing hepatitis C left and right basically start in 2012, and then the really good medication with the first generation DAAs, and then with the really good medications starting to arrive around 2014 and 15. Since the introduction of DAAs, there has been ongoing discussion on the use of Hep C donor positives in Hep C negative recipients. So the American Society of Transplantation in around 2017 had a consensus conference in Dallas about the use of Hep C viremic donors in solid organ transplant. And they were talking about the availability of direct-acting antivirals for the treatment of Hep C, resulted really in a shift in a mindset about how we manage these patients. What really prompted that, we got very excited with the first generation DAAs, which unfortunately we made a lot of patients sick while we were curing them. But with the second generation DAAs, we have a high level of safety and efficacy for these medications, and kind of provide us the opportunity to explore the idea of transplanting organs from donor positive to recipient negative for Hep C. Transplant recipients of all organs can now safely and successfully be treated for Hep C, which may extend to patients and graft survival, which actually have been shown in a lot of studies. Or different organs have been transplanted and treated for hepatitis C. We're not talking about donor positive, we're just talking about the patient himself or herself having Hep C to start with. Because of the organs are frequently discarded and for typically coming from young donors, unfortunately, because the opiate epidemic that we're having right now, our Hep C donors are getting younger and younger, and we're going to talk that a little bit in detail in the next few slides down the road. But that gives us, this approach has the potential to save lives in solid organ transplant waitlist. Organs from these young donors are usually without, who usually have no major underlying liver disease or disease in general, and no or minimal liver fibrosis. These grafts are considered to be better quality than organs from older Hep C viremic donors, which has been kind of the norm for the past few years, where our baby boomers are the highly infected, highest incidence of Hep C infection. So we were, years ago, 10, 15 years ago, which we're going to see in a slide, our average age for Hep C donors was a little bit higher. A lot of these patients had comorbidities or had hepatitis C for a long period of time and had more advanced fibrosis. So what are the benefits of a Hep C donor positive or D positive R negative, which we're going to call it from now just for short? Well, shorter waitlist periods, and decreased drop-off from the transplant list and mortality on the transplant list. Earlier organ transplants leading to less comorbidities and complications at the time of transplants. The sooner you transplant these patients, the less chance of them having any problems and or comorbidities, and leading to a better post-transplant course and outcome. Increased organ utilization. So a lot of these organs were going to be discarded. Healthcare cost savings. So an average hospital stay in around 2000, I think about 16 or 17, was roughly $8,000 for liver patients, and if that included ICU stay, that cost was about $35,000. The cost for and that's for liver patients. For kidney patients, the cost for hemodialysis, approximately for a deceased donor, for patients on the deceased donor wait list, was about $250,000. So if you cut that shorter, and that has been increasing about 10% per year per Optum Health analysis, and if you cut that, you incur a big healthcare savings. So just looking at the wait list, this data from the SRTR from United Network for Organ Sharing. If you look at 2018, roughly about 12,000 patients were added to the transplant list every year, with about a little bit more than that removed from the transplant list. If you look at the bottom part, roughly about 8,000 patients were removed for transplant, but unfortunately, about 1,200 patients died before being transplanted, died on the transplant list. Another 1,200 died, were too sick for transplant and they were removed. And about 1,100 patients were also removed from that, or other reasons were off the transplant list. Majority for these patients were actually a mixture between either died or too sick for transplant, but was not listed at the time of removal. Overall, about 4,500 patients who actually made it to the transplant list will either get removed or drop off, or because of death or acute or worsening condition. So just and the number of liver transplants has been increasing every year. Now we're talking about close to about 8,000 transplants per year. I focus most of my data from UNOS on 2018, because around 2017 and 18 is actually where the concept of Hep C donor positive started to gain traction. If we look at the adult patients listed for liver transplant at the end of each year, the number has kind of been steady around close about to 15,000, 13 to 15,000. But if you look at patients who actually the median month for liver transplant, so obviously anybody with a MELD score over 35, they're get transplanted very quickly, either status 1A or high MELD scores. But patients who are kind of the purgatory, the lower MELD score patients, MELD score 15 to 34, their average or their median wait list in the transplant period was in 2018 was about 9 months, and I think this number couldn't get the data for 2020 is not available out yet for UNOS, but that number we predict that actually continues to increase the median month for transplant on the wait list period, and the reason for that is the new allocation system, which as useful as it is for our really sick patients and increase the allocation for high MELD scorers, and they can draw liver organs from a wider circumference or a wider radius, about 250 miles. The patients with a MELD score of 15 and 20 and 25 are now finding harder and harder to get transplanted. And this includes patients, this is the 8 month or 8.5 month is actually for patients with MELD score 15 to 34. So if you exclude patients with a MELD score over 30, that actually becomes even longer and longer. So the percentage who actually underwent deceased donor liver transplant within a given period of time. So within 6 months, about 35% of patients got transplanted, but most patients, 65% of patients, will actually have to wait over 6 months to get transplant. If we look at the pre-transplant mortality rate, patients who are dying on the wait list, in 2016 and 17, we started seeing an uptick in liver cancer patients. And, at that time, we actually had the 6 month wait period for liver cancer patients. So some of these patients fell off the list because of mortality or progression of disease. But now with the new MELD allocation system, these patients are, for instance, the liver HCC or liver cancer patients are at a disadvantage, because now the maximum they can achieve is 3 minus the median MELD for the region. So our region, for instance, is average MELD score is or median MELD score is 27. So the highest MELD score that these patients can achieve is 24. And even though we perform local regional therapies and try to control their treatments, their chance of having a liver transplant with a MELD score 24 is extremely difficult at this point, and it becomes more difficult in different regions in the country. So if we look at the patients who underwent deceased liver donor, within 3 years of listing in 2015, and we kind of look at Missouri, we're about between 60 and 70% of patients were transplanted within 3 years. That means there's another 30 or 40 patients, 30% or 40% of our patients who are on the transplant list who were not transplanted within 3 years. Imagine a patient who's on the transplant list for 3 years and not getting an organ because their MELD score is not high enough. And we know most of our patients who on the transplant list will have comorbidities, will have in and out of the hospital, will have ascites, complication, portal hypertension. And then their chance of dropping off the list or dying on the list is much higher. And if you go in the Northeast and California, it's actually even worse. If you look at the transplant mortality or patients dying on the transplant list in 2017 and 18, again, our region, region 8 is between 14 and 18% of patients died on the transplant list in that year. Almost 1/5 of our patients, 1/6 or 1/5 of our patients are dying on the transplant list. And again, that's if you look at even at Northeast and California and Texas, it's a little bit worse over there. So looking at the median MELD scores for patient disease or receiving a deceased donor liver transplant, again, our region, it's probably around, we know right now, 2018 was about 28 to 30. Right now it's a little bit, about 27. But if you go again, look at the Northeast and the West, it's about 35, MELD score of 35. So lower MELD score patients don't really have, high hope in these areas to receive a liver transplant. And that's why we had to kind of think outside the box and see what else we can provide these patients and what other opportunities we can look into. If we look at the variations in median MELD score at transplant among adult liver transplants, so average over the country is about 28%. That's the median. I'm sorry, not the average, that's the median. 75th percentile is about 30 MELD score, and the 25th percentile is about 25. So it's really high MELD scores right now. So OPTN currently has no policies restricting transplantation of Hep C infected donors to Hep C negative recipients. And because of the increase in mortality from drug overdose, it's estimated that this will be the main source available for Hep C infected livers in the next decade. We're already seeing an uptick in that, and I think the next slide, well, the following slide, we'll go over that in a second, but it's important to kind of identify who's Hep C donor positive. So quick testing is always a Hep C antibody, and anybody who has a Hep C antibody is considered a Hep C positive. But really, the patients who are viremic, we have to have a NAT testing, a nucleic acid testing, which directly measures the viral RNA using PCR or transcription-mediated amplification TMA, and that's usually detectable with 5 to 7 days of exposure. So if we talk a little bit about Hep C liver transplants, the data that we have for patients who received Hep C, we're talking about Hep C infected recipients to start with, and received organs from Hep C positive donors. There is no difference in patient or graft survival. Using a liver is acceptable if the donor biopsy usually is stage 2 fibrosis or less. For renal transplant, a large observation study in Spain demonstrated that there was no difference in 10-year outcomes between recipients of Hep C who with Hep C, so patients already had hepatitis C and received Hep C positive organs, and they demonstrated there's no difference between the outcome between graft and patient survival. So that kind of encouraged us with the current DAs to look into patients who are Hep C viremic. So if we look at the source of Hep C viremic patients in the 2006 and 2008, majority of our patients were, or the average median deceased donor age for patients who have hepatitis C is 49. But starting in around 2012, with the start of the opiate epidemic, that median age has been rapidly declining, and in 2016 is dropped to 35. And I think I've seen some data more recently, and I think that age is about 32 right now. So since 2000, the death from drug overdose have increased by 137%, including that 200% increase in opioid death. The growing incidence of hepatitis C infection in these overdose victims will likely have them be the main source of hep C viremic donors in the next decade. During the next 10 years, hep C viremic donors are predicted to mostly come from infected young person who inject drugs, PWID, which is kind of the new term that we're using now. So a multi-cause mortality data analysis by the CDC and the OPTN-sponsored disease control potential study predicted that in 2014, using hepatitis C viremic patients with, and we're talking about good quality organs, there about an unrealized additional 300 to 500 opportunities for donations among these patients who injected for patients who inject drugs, and the trend line continues to increase. And this is kind of, though that graph doesn't really represent that statement, this is just looking at the percentage of patients who, or percentage of donors who are hepatitis B antibody positive over the past few years, and the number has been increasing. About in 2018 it was about 15%. So, bearing that in mind, which patient would you like to transplant with a hep C donor positive and recipient negative? So patients who don't really have the luxury of time, patients with acute liver failure and whom the timing becomes extremely critical if they don't get an organ fast enough, if they're on a high MELD zone like the West Coast or the Northeast, or a lot of these patients are transplanted with a MELD score of 35 or above. And if this patient is kind of, a little bit less than 35, if they're 34, they wouldn't be drawing from the 250-mile range area, and there will be a disadvantage. A patient with hepatocellular carcinoma who, now that they're limited with the three average, three minus the average or the median MELD score for the region. So in our region, for instance, as I mentioned, is 27, and so that means these patients will stick with a MELD score of 24, and they have to wait even 6 months to get to that MELD score to kind of ensure tumor stability. But unfortunately, during that period, we'll get a lot of dropout of these patients. And if they're on the East or West Coast, where the average MELD score is at 35, then their chance of getting an organ is even less. Patients with low MELD score who have significant complications from portal hypertension, like our patients with, which doesn't really reflect how ill they are. So patients with primary sclerosing cholangitis, which they will continue, and patients with hepatopulmonary syndrome, which a lot of these patients will continue to carry a low MELD score, usually in the teens to maybe low 20s, until they actually have a severe decompensating event, and sometimes at that point it becomes too late for transplant. So you always have a very small window for transplant for these patients when they get a higher MELD score, but a lot of times they're not even candidate at that point. So you identified your patient that needed a liver transplant. So how to proceed? So identifying the right patient, pretty much almost every patient, except for advanced fibrosis in non-liver patients. So if we have a hep C kidney patients, we're going to just transplant them with kidney alone, we would like to have, we would like for these patients not to have advanced fibrosis. Discussing with the patient and family is very important, and kind of exploring the options, exploring the current lay of the land for transplant in your region is very important, and also getting a special consent for the patient for hep C organs. The AASLD recommends kind of going over the risk of transmission, which is in these patients is almost 100% if it's a viremic donor. Risk of liver disease, if the treatment is unsuccessful or if the treatment is unavailable, if you cannot get the treatment for the patient, which currently with the national guidelines, any patients who have hepatitis C can be treated without any restrictions or limitations to fibrosis score, as opposed to several years ago. risk of graft failure, risk of extrahepatic complications of hepatitis C, such as Hep C associated renal disease, and risk of Hep C transmission to their partners, which is very low. Benefits and especially reduced wait times. And then you also have to document the informed consent separately, other than the consent for liver transplant. Also assure access to Hep C treatments and retreatment as necessary, which will show our experience with that. Also ensure long-term follow-up for recipients beyond their SVR12 or the 12 weeks after end of treatment, which denotes cure. So organ selection. So which Hep C organ would you like? Especially, we're talking here about mostly for liver patients. So should be quality that minimize poor outcomes unrelated to hepatitis C. So less than 30% macrosteatosis. Younger donors are preferred. So if somebody is 75 years old and Hep C, and even if their liver looks good, probably would not be a good donor. We recommend F1 or less if you're going to biopsy them. And in general, avoid DCD because they're or donor cardiac death patients. So that's kind of compounds the qualities or the negative qualities of the organ if they have hepatitis C and their donor cardiac death. So how to follow up? So hepatitis C PCR is, shortly after the transplant is very important. So now we transplanted somebody with a negative recipient with a Hep C positive donor. Checking PCR, we used to check genotype because, early on in the DA or the direct acting antiviral therapies, genotype was kind of important because we can, some medications were better for different genotypes, but not as important. I think we kind of track it now for more academic reasons. Monitoring LFTs very closely because that can actually, delineate when you're going to be treating the patient. We recommend and ASLD is treatment at 12 weeks post-organ transplant or sooner as clinically necessary as in case with elevated liver functions. The ASLD and ISD, Infectious Society, ISDA, Infectious Society of North America, Infectious Disease Society of North America recommends that treating Hep C patients with a pangenotypic regimen recommended when the patient is clinically stable. So the current recommendation by the ASLD and the IDSA is for hepatitis C infected or uninfected recipients with liver graft from Hep C viremic donors is either combination, fixed dose combination of GLEC and PIP, glecaprevir and piperidinavir with no dose changing with a duration of 12 weeks, or sofosbuvir plus vilpatasvir for also 12 weeks. With some consideration to take in mind. So patients with signs of acute liver dysfunction with elevated bilirubin, probably avoid protease inhibitors. Patients, so you can, in this situation, you're going to avoid GLEC-PEP. Specific drug, contraindicated with specific drug DAAs like high-dose antiacid therapy, especially with soft vel. Amiodarone is contraindicated with soft-based regimens, and avoid specific statins like atorvastatins. Consideration of immunosuppression we'll see in the next couple of slides. For patients with kidney patients who receive a Hep C organ, GLEC-PEP for 8 weeks, though the current practice is mostly still 12 weeks for these patients, and soft vel for 12 weeks. Again, the same contraindications, same considerations as mentioned before. How to monitor on treatment. So if you're going to treat, I'll focus more on soft and sofosbuvir and or soft lead and GLEC-PIP. So the top two lines and the fifth line. Basically, cyclosporin, which is not the first line of treatment, there's a 4 or 5 fold increase in the sofosbuvir in area under the curve. So you need to monitor that very closely and drop your cyclosporin, but no interaction with tacrolimus. Ledipasvir doesn't really have any interaction. If we look at GLEC-PIP, again, the same there's 5-fold increase in glycopyrrolate in area under the curve with higher doses. But with tacrolimus, there's a 1.5 or 1.45-fold increase in tacrolimus levels. So you need to follow up these patients very closely and titrate the tacrolimus level as needed. So if we talk about the cure rate post-liver transplant, most studies cite about 92 to 100% SVR rates, depending which study you look at. In our experience, and I'm going to share a little bit more our experience at St. Louis University, since because we started doing donor positive to recipient negative liver and kidney transplants since April 2019. Overall, we had 52 transplants so far, and that number I think is up to about April of May of this year. It's not updated yet to the current day. 12 patients were liver disease, were liver recipients. 39 were kidney recipients, and we also have one patient who received liver and kidney recipients. But that included all patients who were considered donor positive, as in hepatitis C antibody positive. But if we looked at the, look at the viremic patients who are NAT positive, only 6 patients were 6 liver patients, 22 kidney patients, and 1 liver kidney patients. So a total of 29 patients. If we look at the characteristics of these patients, liver disease patients were mostly alcoholic, 44% of these patients, and kidney patients were diabetic and hypertensive in about 90% of these patients. So looking at kidney patients, we're kind of looked at our total length of stay, 6.8 versus 7.4, not drastically different, so it's not inferior to donor negative Hep C donors. ICU length of stay is pretty much similar. Again, 1.7 to 2.4 was not statistically different. But really, what's striking is the waitlist times for kidney patients was dropped from 1,380 days to 82 days. One caveat is we started doing this, and not a whole lot of centers in the region were doing that. So we had a bigger pick of organs, if you might say. But this maybe not as drastic, but this data was kind of also shown in different studies around the country in different regions. Post-operative complications was, and that's any post-operative complications. So any symptoms, any just kind of going over all the side effects or all the post-operative complication, either immediate or long-term. So far, 40 versus 81%. If we shift gears to liver patients, again, total length of stay is 9.8 versus 10.9. Again, not statistically different. ICU length of stay was 3.8 versus 5.9. And we kind of think that's because if you look at the last row, the MELD score at time of transplant was actually better MELD score. We were able to transplant donor positive patients with a MELD score average around 20 as opposed to 27 for donor negative. Again, we're talking only about 6 patients. Postoperative complications was not statistically different since we're talking about 6 patients, so 66 versus 80%. But again, strikingly is the waitlist time or stay on the waitlist was 87 days versus 253 days. I didn't include the liver and kidney patient, which pretty much her waitlist period was much less than our other 4 or 5 liver kidney patients who were done around the same time. So, once these patients were transplanted, most of these patients were treated within 3 months. So, kidney patients, 10 patients received GLEC-PEP, 9 patients received soft VEL, and 2 patients received soft lead. Liver patients, 6 patients received, all 6 liver patients received GLEC-PEP, and the liver kidney patients also received GLEC-PEP. The choice of treatment was up to the discretion of the hepatologist treating the patient. And overall, we had a 94% SVR rate from the first treatment round. So 2 patients relapsed out of 29. And these 2 patients were retreated with soft Velvox, and both patients were actually in the GLEC-PEP group, and they were both kidney patients. So overall, our SVR treatment with either first round of treatment or the 2 patients required second round of treatment was 100%. And to my knowledge, we have not had any issues with insurance, even with the early days in 2019, except from maybe a preferred formulary from one medication to another. But I don't think we had any rejections or denials. And luckily, we're in Missouri. We're one of the kind of forefront states or the leader states as far as treating Hep C patients, where we have early on we had no fibrosis restrictions. These patients were kind of monitored on a weekly basis for their tacrolimus level, liver function test for the first 4 weeks, and then we usually follow them every 2 weeks after that and adjust accordingly. So in conclusion, the number of Hep C donor positive will continue to rise due to opiate epidemic, with younger and healthier donors with better organ quality, and will help with the national shortage of organs, especially with the new allocation system, which favors higher MELD score appropriately. Hep C donor positive and recipient negative liver, kidney, and liver kidney transplant is beneficial to patients with overall less waitlist times, lower MELD scores and comorbidity at time of transplant, and decreased mortality on the transplant list and drop off the transplant list because of illness or comorbidities. It's also of value for patients with lower MELD score, like primary sclerosing cholangitis patients, some of our autoimmune hepatitis patients, PBC patients, hepatocellular carcinoma patients, and hepatopulmonary syndrome patients. Early DEA therapy after transplant is very safe and very effective, with a cited SVR or cure rate of 92 to 100%, depending on study and location. It overall cuts in the healthcare expenditure on the medium and long-term long-term range, with lower morbidities, lower hospital admissions, and with faster transplant for these patients. And we've been seeing a national trend for sooner transplant for kidney patients on dialysis because of how expensive dialysis on the long term is. Long term, or which is basically over 3 years, graft and recipient survival needs to be monitored and reported as this direction gains traction all over the country, and we expect to see more and more patients down the road being transplanted, so we can have more robust studies and clinical data available. And I think that concludes my presentation, and if you be open for discussions.
Well, thank you, Hani. That was just an amazing whirlwind through liver transplantation with hepatitis C patients, which we're seeing, obviously, seeing less of, but they're still out there, especially with the opiate epidemic coming up. We're going to see more and more of these patients. So if anyone has a question, we've got a nice little group here. If you really want to turn on your cameras and ask it directly to Dr. Elbeshbeshy, that'd be wonderful. Please go ahead and do that. As moderator, I'm going to take the lead here and ask you the first question. You had mentioned earlier about livers going unutilized. Can you know the number of that, and why is that? Why do livers go unutilized?
So this was before that we started using these Hep C donor positives. So this was kind of an estimate by UNIS. At that time, I mean, if these patients didn't have a Hep C organ in 2014 and 15, we were only transplanting Hep C organs and Hep C positive recipients. So if there is no recipient high enough, or the MELD score patient would, it didn't go down all the way down, or it's not, I mean, there's a lot of factors that why a Hep C recipient would not be getting that organ. An estimate was about 300 to 500 at that point. We don't have a clear cut. I've tried to look at the data right now. Now it's that we're doing more and more Hep C organs in negative recipients. I tried to look at the data from UNIS, and that wasn't available yet. I actually reached out to a couple of my contacts in the OPTN or in the UNIS, and I'm hopefully getting this data probably in the next few weeks or so, because they've been actually looking at these numbers.
Very good. Any other questions?
And even if you're camera shy, I know Steve said if turn your camera on. If you're camera shy, that's fine. You can go ahead and ask questions without turning your camera on. I won't feel offended. I've been doing Zoom long enough that we're used to black squares or black rectangles.
I always like seeing people's faces, though. Getting out there and being seen is the way to go. So.
One day.
Hey, honey, another question that I just thought of is Hep C donor positive to Hep C negative recipient. Is that seen throughout the entire country now? Is there some parts of the country that don't allow that? It certainly seems from the data that you presented that the cost is certainly a long save. It saves a lot on patients who are on the liver transplant list for shorter periods of time. Is this kind of standard of care now across the country?
So it is across the country. So nationally, as I showed one of the slides, that the OPTN or UNOS does not have any restrictions on hepatitis C donor positive, and it's left up to the individual transplant centers. We started, as I said, at St. Louis University in April of 2019. So we've been doing this for about 2.5 years, close to 2.5 years. So it's again up to the individual center, but it's gaining traction, in most centers in the country. And I don't know exactly. I was kind of trying to look at this data up when I was preparing this presentation from UNIS. It's not publicly available yet, but I think I know of at least 25 transplant centers are doing this, in the country, and this is just kind of from talking to my colleagues and all over the country. But I know it's not 25. I know it's more than that, but that's what I know of. So I said it's not. There's no restrictions. Early on, I think that the concern was getting access to treatments. What insurance company is going to say, since is this kind of nobody wanted to test the waters. But I think we were, as I said, we were lucky enough in Missouri. We don't have any restrictions on Hep C. They don't question what level of fibrosis, and that's kind of to the efforts of Dr. Bruce Bacon. He's started that movement, and with legal action early on, and was able to get the state to remove any restrictions for Hep C treatment patients. So that kind of paved the way for us to kind of not feel maverick, but feel confident in us that we can get treatment for these patients. And I think that was kind of the holdup for most centers around the country. I think that's not the case anymore, especially we have strong data showing that these patients have the same SVR rates as Hep C organ or Hep C post-transplant patients, which is not any different than non-transplant patients in general. We're talking about 98 to 100% cure rates in most liver patients. And certainly with our own experience with our patients, we're able to cure all of them.
Definitely, I remember those days when we had to send in all this information, and they wanted to not treat any patients with F1s and F2s, and we had to send all this information to try to get our medications covered by the insurance company. So we've come a super long way from the interferon days, of course. So
yeah, I mean, now that a case in point is opiate epidemic. A lot of these patients are getting infected from other patients. So if it's not an issue right now, but if we had limited continued to limit the lower fibrosis score patients, the non-fibrotic patients in general, well, these patients tend to be younger patients. These patients tend to be in the opiate kind of epidemic pool, and we probably would be seeing a lot more overdoses, a lot more Hep Cs in the country. I think the most recent data showed about 70 to 100,000 newly infected patients every year. Back in 2012, we're kind of high-fiving and saying we only get 15 to 20,000 newly infected patients, and by 2030 we're going to get rid of this completely. Well, I remember it used to be 2025 or 2020, but now that's, that date is set back to 2030. But we're getting more and more Hep C infected patients as we speak. So unless we kind of target these patients early on and treat them with, when they're, even with less fibrosis, which luckily it's kind of been all over the country now, most except for a very 2 or 3 states that still put some restrictions on the fibrosis level. I think Mississippi and Arkansas and Louisiana are the 3 states that come to mind.
Wow, fantastic. Any other questions for Dr. Elbeshbeshy before we move on and kick it back to our lovely host, Jackie? Well, without any more questions, Hani, once again, amazing talk, amazing data. We are once again on the forefront in St. Louis of doing new and fun things in the liver world. So we appreciate your help tonight in making us understand that. And once again, we want to thank you very much for presenting tonight.
My pleasure. Anytime. I'll be happy to present further data as we compile it down the road.
And great.
On behalf of the American Liver Foundation, I just want to thank all of our guests for joining us this evening and taking some time out of your day to further educate yourself by hearing the wonderful remarks and the wonderful moderating by our gentlemen, Dr. Elbeshbeshy and Dr. Stephen Fern. And we hope to see you at other programs. I will send a link to this recording once it's available, and have a great evening.